For example, I'm going to choose RUNX1, familial platelet predisposition. If you look at this particular genetic predisposition, you can get this diagnosis when you're a newborn baby. And what we know in the literature so far is that there's a 30 to 40% transformation rate to acute myeloid leukemia in your third or fourth decade of life. So I guess the question for us is, what does one do with families with a child who's diagnosed with a low platelet count and RUNX1 FPD? How do you understand what's the best mechanism for monitoring these patients over time? You want to maintain the right quality of life balance. You want to ensure that the child is able to access all the fun things that children need to do. You want to make sure that adolescence is fun-filled when you go to university and not always worried about bruising or bleeding. But you also then don't want them to worry when they're adults and a time when life should actually be full of possibilities, to include a very life-threatening possibility of leukemia. So, for example, with the RUNX1 cohort, what would be really great is to try and understand how many of these patients are there in the United Kingdom, across what age groups do they exist. And we need to develop that continuity of care from pediatrics to adolescents to young adults, so that then we can actually inform the families, this is best practice. This is the best balance between achieving a good quality of life, and this is when your clinicians will alert you there's trouble ahead, and maybe we can try and circumvent that in a different way. So I think RUNX1 is an example. There are others which are more traditional bone marrow failure conditions, like Shwachman-Diamond syndrome. Now that is a multi-system disorder, and in those patients you might either go to a gastroenterologist with gut-related problems and not hematological problems. And in those patients, you need the multi-specialty input. You need to speak to your gastroenterologist, you need to speak to the hematologist, you need to have that sort of coordinated care between multiple specialties, especially for conditions where you have a germline predisposition and many, many systems get involved. So in essence, what you really need is multi-specialty, multidisciplinary support for these families, with really underpinning all of it is patient advocacy. Nothing can move forward unless you have patient advocacy in any of these conditions.